Hey guys, here is your cardiopulmonary lecture. It is a little bit of a long one, so feel free to take breaks whenever you want to. We are going to just go ahead and dive right in. And a lot of this is going to be review and sort of a carryover from the aerobic lecture that we also did. So basic anatomy of the heart, we have the apex of the heart and the base, top and the bottom. Your right atrium on the right side, which is receiving all the deoxygenated blood from the body, from the superior and inferior vena cava, which is then pumping the blood to the right ventricle. From there, it's pumped out into the lungs to become oxygenated. It comes back into the left atrium, down to the left ventricle, and then out through the aorta and pumped to the rest of the body. The valves of your heart, on the right side, we have a tricuspid valve. Then we have the pulmonic valve at the pulmonary artery, the mitral valve or the bicuspid valve on the left side of the heart, separating the left atrium and ventricle. You have the aortic valves, the atrioventricular valves, and semilunar valves, which are your aortic and pulmonary valves. Major blood vessels of the heart. We have your aorta, which contains all of the cardiac output. Your ascending aorta travels to or supplies the head, neck, and arms. Your descending aorta delivers blood to the lower body and your internal organs. Your superior vena cava drains from the upper body. Your inferior vena cava drains or brings the deoxygenated blood from the lower part of the body. And then we have the pulmonary artery, which is taking the deoxygenated blood to the lungs. There are a couple of cardiac reflexes that we're going to talk about, three, really, your baroreceptor reflex, your Bainbridge reflex, and chemoreceptor reflexes. These are all reflexes. They're all going to work to try to maintain homeostasis in one way or another. So the big thing I want you to remember about each one of the reflexes is what bodily function they're controlling. For example, the baroreceptor reflex is the first one. This is also known as, this helps to maintain a constantly relatively stable blood pressure. Okay, so baroreceptor is going to maintain blood pressure. There are mechanoreceptors that are found in the wall of the heart, the carotids, as well as the large arteries that help to sort of sense and trigger this reflex. The most sensitive receptors are in the carotid sinuses and the aortic arch. They're activated when your blood pressure is above 60 millimeters of mercury. And it results in vasodilation, secondary to the inhibition of vasomotor centers in the brain, as well as a decreased heart rate and strength of contraction, secondary to vagal stimulation. Really, what all that boils down to is that if an increased blood pressure is detected, it will lower your heart rate. And if a decrease in blood pressure is detected, it will increase your heart rate, again, to try to maintain a stable blood pressure. The Bainbridge reflex is also known as the atrial reflex. There are mechanoreceptors in the wall of the right atrium that responds to an increase in pressure and stretch. So if it detects increased blood volume in the right atrium, it will increase your heart rate. It can also slow down the heart if it's beating too fast. So the Bainbridge reflex works with the baroreceptor reflex to help to control and maintain heart rate and blood pressure. Third is the chemoreceptor reflex. This responds to the need for increased depth and rate of ventilation because, again, this is monitoring chemical levels in the blood, especially carbon dioxide and oxygen. And so if imbalances in these levels are detected, then it will either increase or slow down your respiration rate in order to bring in or expel more oxygen and carbon dioxide. So common pulse locations, and I know you guys have practiced all these at one point or another. So we have the carotid pulse in the neck, the brachial in the arm, which we tend to use more for kids, the radial pulse, which is probably one of the most common sites that we're going to take pulse to determine heart rate. Over on the other side of the wrist, we have the ulnar pulse. You have the femoral pulse in the femoral triangle, the popliteal in the popliteal fossa was where I was going with that. A posterior tib on the medial aspect of the ankle and foot, and dorsalis pedis on the top of the foot. All right, some diagnostic tests that you might see. And I know that you guys have probably talked a lot about these or talked more about these in patho. So we're not going to spend a ton of time on these, mainly just kind of going over, again, how this is going to play into rehab. So cardiac catheterization or angiography, this is when the coronary arteries are injected with a contrast dye and then they're viewed under fluoroscopy. This is used primarily to detect occlusion or blockage of the coronary arteries. So again, this is a major cause of heart attacks or myocardial infarction if the heart muscle itself is not getting enough blood supply. So the angiography is just basically getting a view of those vessels to be able to tell if the heart is getting enough blood supply. It's usually done more on the left side of the heart. And again, we're just looking for blood supply. Straight cardiac catheterization can be used to look at either the left or the right side of the heart. It's going to measure intercardiac, transvalve, and pulmonary pressures. It can also measure blood gas pressures, which we will use to assess blood pressure and oxygen saturation levels. This is looking more inside the heart to determine the functioning of the heart and the valves. So the angiography, again, was looking at the blood vessels on the external part of the heart. The straight cardiac catheterization is looking more inside the heart itself. Continuous hemodynamic monitoring, also known as the Swan's-Ganz catheter, can be used to detect heart failure. It's going to monitor cardiopulmonary pressure. So we have a balloon-tipped catheter that's connected to a transducer that measures pulmonary arterial pressure, cardiac output, and venous saturation. It can evaluate the left ventricular function in the ICU or telemetry unit, and it measures pulmonary resistance and tissue oxygenation. Like I said, it could be used to detect heart failure or sepsis. You can be used during therapy to monitor the response and assess the effectiveness of different cardiac drugs. ECGs or EKGs, electrocardiograms. I know you guys talked about these and looked at the different waves and things like that in patho. So for this, there's going to be surface electrodes placed on the chest, and it measures the electrical activity of the heart. Typically, there's 12 leads that are placed in certain places around the heart. They can assess cardiac rhythm, diagnose the location, extent, and acuteness of an ischemic condition, and evaluate any changes. So they'll monitor from one time to the next to see if there's been anything major that's been happening. Exercise stress test is one that probably means most to us in therapy. We need to know the results if the patient has had an exercise stress test, especially if they've had any type of cardiac event. So we're going to talk a little bit today, a little bit later on, about cardiac rehab. And so an exercise stress test is usually part of that. So it's tests that utilize treadmills, bikes, steps, any type of cardio equipment, basically, to monitor heart responses to increased workloads. It's used usually with an ECG and blood pressure. It's going to monitor both of those things with exercise to determine the patient's exercise capacity, if there's any cardiac dysrhythmias, and any type of coronary artery disease. Again, this is going to be a major player in cardiac rehab if the patient's had any type of cardiac event. Holter monitoring, I don't know if they actually call it this anymore because the Holter was kind of the machine that you used to wear around with you for sort of some constant continuous monitoring. Now it's come a long way. They have like little patches with little devices that you can just wear as almost like a sticker, and that will send or track your heart for an extended period of time. So this is basically portable type monitoring. So continuous ambulatory monitoring of cardiac rhythm for 24 hours or longer. A lot of people that I've seen that had these lately, it's oftentimes at least a week, if not 2 or even longer. So they're looking at cardiac rhythms to determine the effectiveness of medications if the patient's taking any cardiac meds, cardiac disease symptoms, pacemaker functions, things like that. This is often something that they'll do if people are noticing like arrhythmias, flutters, just something feels not right, but it's not a constant thing. And of course, it's never going to do it while you're at the doctor. So they will usually prescribe some type of like monitoring so they can look at you for a week or two and try to catch and see what's going on when you have these arrhythmias or things like that. All right, right-sided versus left-sided heart failure. So some of the things we'll see with right-sided heart failure are an enlarged liver, ascites, which is the buildup of fluid in the peritoneal cavity, jugular venous distension, pitting edema, fatigue, nocturia, which is increased urination at night, cyanosis, so blueness or color to the skin, pleural effusion, anorexia, or unexplained weight gain. For left-sided heart failure, we're more likely to see pulmonary edema, dyspnea or shortness of breath, nocturnal dyspnea, so it's worse at night, a cough, bronchospasm, fatigue, oliguria, which is a decreased production of urine, cyanosis, and tachycardia. There's a decent amount of overlap between those symptoms. Again, with heart failure, we're going to see either side some serious consequences from that. Causes of right versus left-sided heart failure, and left-sided is much more common, but right-sided could be mitral stenosis, pulmonary disease, tricuspid or pulmonic disease, infective endocarditis, or left-sided heart failure can then trigger right-sided. So left-sided could be things like hypertension, coronary artery disease, so you can see why that's much more common, aortic valve disease, congenital heart disease, and connective tissue disorders. Norms for your vital signs. I know you guys have had all these before. Normal blood pressure, 100 to 140 over 60 to 90. Generally, again, 120 over 80 is considered normal. Anything above that is considered pre-hypertension or hypertension. Blood pressures are a little bit lower normally in children. Pulses, again, infant and children are going to have higher pulses or heart rates than adults. Normal resting heart rate for adults is usually 60 to 100 beats per minute. Bradycardia is going to be less than 60 beats a minute. Tachycardia is going to be greater than 100 beats per minute. So indications for cardiac rehab. These would be the patients that we do see specifically for cardiac rehab and do probably need a bit more continuous monitoring than our typical patients. So someone post a myocardial infarction or heart attack, stable angina, coronary artery disease, hypertension, end-stage renal disease, someone with a pacemaker, peripheral vascular disease, diabetes, heart transplant, and status post a CABG, coronary artery bypass graft surgery, which can often be a treatment following a heart attack. So contraindications for exercising a cardiac patient. So again, if you have a patient who has any type of known cardiac history, these are kind of some special precautions that we want to take with them. But honestly, I can say, kind of just looking at this list, if any of my patients showed any of these symptoms, we're going to discontinue therapy. So if their heart rate increases more than 50 beats per minute with just a low level activity, that's a sign that their heart is not tolerating activity well. If their systolic blood pressure is greater than 210 millimeters of mercury, or their diastolic is greater than 110 millimeters of mercury, that's high blood pressure. Probably not the best time to exercise them. A systolic blood pressure that decreases more than 10 millimeters of mercury when exercising. If they have chest pain, stable, unstable, probably not a good idea to exercise. Confusion or extreme fatigue, uncontrolled arrhythmias, feeling that flutter kind of in their heart, and acute embolism or uncompensated congestive heart failure. There are 4 major stages of cardiac rehab that we're going to talk about, and as PTAs, we're involved in pretty much all of them. Phase 1 is going to be physician referral, typically while they're still in the hospital following whatever cardiac event they had. Phase 2 is post-hospitalization, so they're typically moving into an outpatient treatment center at this point. Phase 3 is a continuation of Phase 2. We typically progress the exercises and add more strengthening at this point. And then Phase 4 continues throughout the rest of their life. Cardiac rehab really is a multidisciplinary approach that involves PT, OT, the physicians, nursing, nutritionists, and social work. So Phase 1, once the patient is medically stable, they are typically referred to physical therapy. During this time, we do a lot of patient and family education about precautions, about what happened, about lifestyle changes, about how we're going to move around and things like that. And basically what we're going to focus on this point is self-care with constant monitoring of vitals. We're doing extremely low-level exercise at this point. Things like just some active range of motion, ankle pumps, heel slides while they're in bed, maybe working on some upper extremity movements, especially if they've had like any type of open heart surgery or anything like that. The chest wall has been cut open. It's going to restrict their upper extremity movement. Our goal at this point really is ambulation, to be able to get them up and get them moving, and just be able to, again, do some self-care. A lot of times our therapy sessions are going to be starting with just getting them to sit on the edge of the bed and spending more and more time in an upright position, because that can be difficult. That change from supine to sitting, you guys have seen that with a normal quote person and how that can affect your heart rate and your blood pressure. So someone who's just had some type of major cardiac event, they're not going to respond to that very well either, usually. So again, we could just be sitting on the edge of the bed. We could be working on transfers from the bed to the bedside chair. We could be ambulating from the bed to their bathroom so that they can go to the bathroom on their own, or maybe a bedside commode. This is low-level stuff, but it's really important stuff for the patient to be able to do. The patient's going to want to be able to go home and be able to get themselves to the bathroom and get themselves dressed. And to do that, they've got to be able to tolerate an upright position, and they've got to have the range of motion to do that. So the patient will typically be seen daily, so every day. You'll do a treatment session with them, usually about 30 minutes or so at a time, sometimes even twice a day for shorter periods, depending again on how they tolerate exercise. Then we move into phase 2 once the patient is discharged from the hospital. So this can last anywhere from 2 to 12 weeks, or starting week 2 and then beyond. During phase 2, the big thing to remember is that the patient should still be supervised during all activities. And when I say supervised, I also mean monitoring blood pressure, heart rate, especially heart rate. Heart rate and oxygen saturation levels, putting one of those little monitors on their fingers, it's super easy to do. It takes really little time, little effort, and that's going to tell us a lot about how they are responding to exercise. So we are going to want to continue to monitor vitals pretty regularly during this phase. So we're going to try to increase their functional capacity with exercise. We're going to continue with patient education on risk factors. We are hoping to get the patient independent in self-care. They're typically seen 2 to 3 days a week. And our big focus here is going to be on ambulation. We're going to try to increase them by about 4 to 6 weeks, up to about 20 to 30 minutes a day of some type of aerobic activity. And walking is going to be the most common type that we'll see. Most patients are going to have an exercise tolerance test at the beginning of an outpatient program. And so during that test, one of the things that they're going to determine is what that patient's maximum heart rate should be. We talked in the aerobic lecture about how we determine max heart rate, right? Simple formula, 220 minus the age, that's your max. And then typically when we're working out, we're not ever working out at our max heart rate. We're working out at 60, 70, 80% of that. For patients who've had a cardiac emergency, and the reason we do it, one of the reasons we do an exercise tolerance test is that we might not be able to use that simple formula for them. We're going to determine their max heart rate as anywhere that they start to develop symptoms. And then we're going to back it down off of that. So the exercise tolerance test is going to test and see if they have any symptoms when they're doing exercise. And then we're always going to stay below those levels to try to make sure that the exercises that we're giving them are not going to trigger any type of cardiac symptoms. Phase 3, like I said, is a continuation of phase 2. It can last 6 to 8 weeks beyond that. Again, we're going to progress our exercise training to try to increase physical fitness, level of endurance. But again, this is where we typically add strengthening on. So in phase 2, we were mainly doing a lot of cardio type exercise with them. Some minor strengthening or a little bit of strengthening. They have to be strong enough to be able to tolerate the cardio type of exercise. But in phase 3, we do begin more specific strengthening. Generally begin with smaller muscle groups. It's really important to avoid the Valsalva maneuver with this patient population. And we're going to also use the rate of perceived exertion of the Borg scale to help us determine how hard the patient is working. The Borg RPE scale is a subjective scale. We're going to see this in lab. You guys are going to use it. But it's a subjective scale where a patient sort of rates how hard they're working. And as subjective as it is, they've actually found that there's a pretty close correlation between RPE scales and heart rate. So in the absence of being able to measure heart rate, we can use RPE scales. If the patient develops any symptoms during this time, we will cease strengthening exercise. So again, a symptom-limited exercise test will be done, again, hopefully much before they start this phase. This phase usually is 1 time per week in therapy. They will continue to do exercises on their own at home or at a gym. 4 then lasts throughout the lifetime. It's designed to promote optimal health. The patient does need to be independent with monitoring their own exercise. They should have demonstrated a stable cardiac status throughout the previous 3 phases of rehab and demonstrate no contraindications to exercise, which again was a couple slides ago, that list of symptoms like the super high blood pressures, chest pain, confusion, extreme fatigue, things like that. This mentions MET capacity for exercise, but like I said, we are typically looking more at RPEs now, rate of perceived exertion, how hard the patient feels that they're working. So some examples of exercises they can continue with are brisk walking, swimming, dancing, anything that they like and that they tolerate. During phase 3 and 4, again, these are your end phases, we should do a proper warm-up before we just jump into activity. And then again, our goal is to do anywhere from 20 to 60 minutes of cardiac or aerobic activity. So walking, stationary bikes, some strengthening. Again, do be careful of Valsalva maneuvering. And so isometrics are sometimes a culprit for that, against trying to tighten and squeeze and hold a muscle. And then we want to cool down again at the end of our program. Exercises, again, options, treadmills, stair climbers, bikes, rowers, cross-country ski machines, steppers, UBEs, whatever the patient enjoys, whatever they're more likely to stick with, let's have them use that. If a patient reports chest pain during exercise, exercise should be stopped immediately. The patient should sit or lay down. Blood pressure and heart rate should be assessed. If they have nitroglycerin, that should be taken. It should produce kind of like a tingling, burning sensation if it's effective. Wait 5 minutes and repeat if the symptoms persist. They can potentially take a 3rd dose, but if they're still having symptoms, I'd probably call EMS at this point. If the patient doesn't have nitroglycerin or if their symptoms get worse, you should contact EMS just to be safe. Again, the role of the PTA in inpatient, we're going to be monitoring heart rate, blood pressure, ECGs, monitor their heart rate when they're exercising, use exertion scales like that Borg scale, promote proper breathing, and potentially monitor METs. In outpatient, initially, we're going to monitor heart rate, blood pressure, and ECG. Probably not ECG so much, but definitely heart rate and blood pressure you should still be checking on. And then we're going to start to wean off constant monitoring. Again, we want the patient to become independent in monitoring themselves. And then exercises should be based on maintaining the patient's target heart rate. All right, we're going to switch into pulmonary conditions now. So test physical therapy. This is therapeutic exercises used to treat patients with acute or chronic lung disorders. The goals of intervention are going to be to prevent airway obstruction and decrease secretions in the lungs, mobilize those secretions if they are there, to improve their airway clearance and improve the ease of ventilation. So that will decrease the energy that they need to breathe, increase their cough effectiveness, increase their chest mobility, prevent or correct postural deformities that can be associated with respiratory diseases, and just in general improve their endurance and exercise tolerance. Respiration is the general term to describe the gas exchange within the body, and it can be either internal or external. External is the exchange of gas at the alveolar membrane and the pulmonary capillaries, and then internal is the gas exchange within the cells themselves once the oxygen starts to circulate through the body. Ventilation is the exchange of air to and from the body during inspiration and exhalation. The muscles of respiration, your diaphragm is one of the major muscles, or probably the major muscle, the primary muscle of respiration during relaxed, normal breathing. It moves downward with inspiration, and it's innervated by the phrenic nerve, which is C3, C4, and C5. Again, you may have talked about that a little bit in neuro with your different spinal cord levels and how that can affect the diaphragm and breathing. Your external intercostals maintain the space between the ribs during normal breathing. It can also lift the ribs during inspiration. Accessory muscles, this is muscles that might get called in when breathing is difficult. So the SCM can elevate the sternum. The upper traps can elevate the shoulder and indirectly then elevate the ribs and fix the neck to give the scalenes a stable pull. The scalenes can elevate ribs 1 and 2. And pec major and minor, serratus, can also help to elevate the ribs and expand the thorax. Expiration is typically a passive process with relaxed breathing, meaning that the diaphragm just relaxes, the ribs drop, and that kind of forces the air out of the lungs. Muscles of forced expiration, kind of an active or forced expiration, are going to be the abdominals, which help to pull the thoracic cage down, and your internal intercostals, which depress the ribs. Thorax enlarges in 3 planes during inspiration. It enlarges anterior to posterior as the sternum and ribs move upward. It enlarges medial and laterally as the ribs flare, and vertically as the central tendon pulls the diaphragm down. Ventilation, again, is movement of air in and out of the body. Respiration is the gas exchange between the blood and the tissues. Compliance refers to the elasticity of the lungs, and normal lungs are very compliant or elastic. Resistance is the ability of air to flow through the system, which can be affected by the size of the opening of the structures, the presence of secretions like mucus in these airways, smooth muscle contraction, constricting the structures, and elasticity of the lung. During normal breathing, the airways are going to widen on inspiration and become more narrow or close down with expiration. Flow rates are the amount of air moved in or out in a given period of time. FEV1 is your forced expiratory volume. It's the amount of air expelled in a minute. It reflects the ease of ventilation, and a decrease in FEV1 is indicating poor ventilation. They often use this and compare it with your forced vital capacity, which again are some values that we'll review here in just a minute. And your FEV1 over your forced vital capacity should be greater than 70%. General anatomy of the pulmonary system, we have the tracheobronchial tree, 23 branches all the way down. Your trachea runs from about C6 to the sternal angle at T5, and then it bifurcates or divides at the carina at T5. You have right and left bronchi. Right is almost vertical, left is a little bit more oblique, and then you have the branching of the different to the different lobes of the lungs. So we have 3 branches on the right side and 2 on the left. Then we go into segmental bronchi, the bronchioles, the terminal bronchioles, your respiratory bronchioles, which then finally end in alveoli, which in the adult lung we have about 300 million, and this is where gas exchange occurs. The tracheobronchial tree is going to conduct air. It's going to humidify and trap small particles to clean the air so that those particles hopefully don't make it down to our lungs to cause infection. It'll move mucus upward by cilia, moving that to get it, again, out of the system so it doesn't stay trapped in our lungs and cause us to get sick. It warms the air and elicits a cough reflex. Again, remember that we have 3 lobes on the right lung and 2 lobes on the left. All right, we're going to go over a lot of different values here, and if you don't remember all these abbreviations, that's fine. There's a slide about each one of them coming up. But we have TLC, total lung capacity. TV is tidal volume. IRV is inspiratory reserve volume. Then we have expiratory reserve volume. RV is residual volume. IC is inspiratory capacity, VC is vital capacity, and FRC is functional residual capacity. So like I said, we'll talk a little bit about each one of those. So total lung capacity is the total amount of air contained in the lungs after a maximum inspiration. So it's actually made up of 4 different volumes, or can be divided. So we have our tidal volume, which again, remember, is our just normal relaxed inhale and exhale. Our inspiratory reserve volume, what's left after a normal inspiration. Expiratory reserve volume, what's left after a forceful expiration. And then the residual volume, the amount that's always just left in our lungs no matter what. Your vital capacity plus your residual volume makes up your total lung capacity. This is about 6,000 milliliters in a healthy adult. Do not worry, I'm not asking you to memorize the actual milliliters, the numbers, the things like that. They're included on these slides just so that you can kind of make comparisons, but you do not need to memorize those or know those. Tidal volume, again, is the amount of air exchanged during a normal relaxed inspiration followed by a normal relaxed expiration. So tidal volume is just your normal sitting breathing. Inspiratory reserve volume is the amount of air you can forcefully breathe in after a resting inspiration. So you can normally breathe in and then you can force yourself to breathe in a little bit more. Typically, these values are going to be slightly higher in males because they typically have a little bit larger lung volume because of being a little bit larger. Oops, did I miss one? Yes. Expiratory reserve volume. This is the amount of air you can exhale after a normal resting expiration. And then residual volume, the amount of air that's left in your lungs after a maximum expiration. So no matter how hard you try to blow all the air out of your lungs, there's always going to be some air left in there. This is going to increase with age and with restrictive obstructive pulmonary diseases. Your inspiratory capacity is the amount of air a person can breathe in after a resting expiration. Your functional residual capacity is the amount of air that remains in the lungs after a normal resting exhalation. It is your expiratory reserve volume plus your reserve volume. And this is the pointed ventilation where the forces that expand the thoracic wall are in balance with the forces that tend to collapse the lungs. And vital capacity is your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume. So this is a max inspiration followed by a maximum expiration. This is going to decrease with age. It's less in supine as compared to an erect posture, and it decreases in the presence of restricted and obstructive pulmonary diseases. Here's a chart that kind of helps break things down a little bit. Here's volumes. Again, I don't expect you to know these numbers. Here's the chart that I like the best. So this kind of shows you, here is this normal breathing. Here's your inspiratory reserve volume. Here's your expiratory reserve volume. And then again, here's your residual volume, the amount that you can't get rid of no matter what. So then it shows you inspiratory capacity, functional residual capacity, vital capacity, and you can kind of see everything that goes into making these up. So if that chart helps, cool. If not, that's fine too. So some chronic airflow limitations or lung diseases that limit airflow. These are going to be things like COPD, which we have chronic bronchitis and pulmonary emphysema that fall under that category. And then we'll talk about asthma as well. With COPD, again, this is a fairly broad categorization or diagnosis. We'll see someone who is easily fatigued, has shortness of breath, probably participates or does some pursed-lipped breathing. They have a chronic non-productive cough, so they're coughing a lot, but they're not actually coughing up any secretions. You might see sort of barrel-chestedness, a widening of their chest because of using those accessory muscles a lot, wheezing, digital clubbing, and generally thin in appearance. In pulmonary emphysema, we see loss of the lung elasticity and hyperinflation of the lung. We'll see shortness of breath and the need for an increased respiratory rate. There can be air trapped in the lungs. We have loss of elastic recoil in the alveolar walls. We have overstretching and enlargement of the alveoli and collapse of the small airways like the bronchioles. With emphysema, the alveoli are becoming damaged, and this is going to limit the amount of oxygen that is able to be circulated through the blood. With pulmonary emphysema, some of the symptoms that we might see lead to this pink puffer sort of diagnosis. So we see an increase in carbon dioxide retention, which makes them a little more pink. We don't see cyanosis with this. We might see pursed-lipped breathing, again, another ineffective cough, barrel chestedness, shortness of breath, exertional dyspnea, so shortness of breath when they do activity, easily fatigued, wheezing. They speak in short, jerky sentences because it's hard to get a full sentence out. Frequent upper respiratory infections, use of accessory muscles to breathe, digital clubbing again, thin appearance. And this can lead to right-sided heart failure. Chronic bronchitis, this doesn't affect the alveoli. This affects more the bronchi and bronchioles. This can be inflammation caused by chronic exposure to irritants, especially tobacco smoke. We'll see inflammation, vasodilation, congestion, mucosal edema, bronchospasm. Again, this is affecting the airways, not the alveoli, and produces large amounts of thick mucus. With this, the cilia are destroyed, so they can't move or mobilize that mucus, so it tends to build up in the lungs. These are the patients we see as the blue bloaters. They have the cyanotic or dusky type appearance. They do have a cough, but this one they are going to actually cough up mucus. We can see edema form. They'll have an increased respiratory rate, also exhibit exertional dyspnea, increased incidence in heavy cigarette smokers, cardiac enlargement, and again, using those accessory muscles to help breathe. Asthma, this is going to look much different. This is intermittent and reversible airflow obstruction that affects the airways, again, not the alveoli. The airway obstruction occurs due to inflammation and airway hyperresponsiveness. So you will typically, or people who have asthma will typically have a rescue inhaler. The rescue inhaler is one that they can take whenever they're having asthmatic symptoms. It is a fast-acting bronchodilator. That's what the rescue inhaler is going to do. Because typically when someone's having an asthma attack, it's because their bronchioles are becoming very narrow and they're not able to move enough air. And so taking the rescue inhaler will help to open up those bronchioles and help them to breathe a little bit more easily. We do see asthma a little bit more commonly in males, typically diagnosed before age 12. We'll see signs and symptoms of hypoxia, anxious. Obviously, if you have difficulty breathing, that can make you kind of nervous and anxious. And we might see an expiratory wheeze. So when they exhale, you can hear a wheezing. If the symptoms don't respond to their rescue inhaler within 30 minutes, they should seek immediate medical attention. Cystic fibrosis is a genetic disease that affects multiple organs and it lethally impairs pulmonary function. It is typically present from birth, usually diagnosed in early childhood. Many clients do now live into adulthood because of the advances in treatments. It causes an error in chloride transport, which then produces the mucus with low water content. So it's a really thick, sticky mucus. So we see problems in the lungs, pancreas, liver, salivary glands, and testes. Some non-pulmonary manifestations that we'll see, the adults are usually smaller and thinner due to nutrition issues. We can see abdominal distension. We see GERD or gastroesophageal reflux, rectal prolapse, foul-smelling stools, steatorrhea, which is increased fat in the stools, vitamin deficiencies, and increased incidences of diabetes. Again, this does affect multiple systems, not just the lungs, so we will see some other things going on as well. The pulmonary manifestations or symptoms that we're going to see are frequent respiratory infections, chest congestion, limited tolerance to exercise, increased cough and sputum production, use of accessory muscles for breathing, so we might again see that barrel chestedness, decreased pulmonary function, changes in chest x-ray results, and increased anterior-posterior diameter of the chest, again, barrel chestedness. Goals of therapy are that we want to avoid mechanical ventilation. We don't want these patients to end up on a vent. So a lot of what we do is going to include airway clearances. We're going to try to increase oxygenation by getting that mucus out of their lungs so that they can move air more easily. There are some antibiotics that can help treat the symptoms during flare-ups. There is a heliox therapy, which is half oxygen, half helium, and bronchodilator and mucolytic therapies can also help. As far as surgical treatments, lung and or pancreatic transplantation aren't really going to fix or cure the problem. What will happen is the disease process is still there, and so it will eventually affect the new organs, but it can extend life by 10 to 20 years. They have both single and double lung transplants possible. Again, this is going to be a collaborative management, usually between multiple disciplines, at least sometimes PT, OT, medicine, physicians, nursing, social work. Physical assessment, we want to hopefully aim for no manifestations between attacks, audible wheeze, and increased respiratory rate. Again, we might see use of accessory muscles and barrel-chestedness from using those muscles. Again, these are the patients that we might do postural drainage or chest PT with, and our goal is to prevent accumulation of secretions in the lungs or decrease the secretions that are present. Contraindications to postural drainage include an active hemorrhage, so bleeding anywhere, other acute conditions, cardiovascular instability, or recent neurosurgery. Other contraindications include congestive heart failure because typically they won't tolerate the different positionings or the moving of the fluid, pulmonary edema, significant pleural effusion, pneumothorax or collapsed lung, cardiac arrhythmias, history of a heart attack, unstable angina, or pulmonary embolism. Postural drainage, again, these are manual techniques that we use to try to mobilize secretions. We'll talk a little bit, and I have a handout that's posted for you guys about the positioning for this. The bottom line is with postural drainage, what you're going to do is you're going to listen to the different lobes of the lungs. So again, this is why it's important to kind of know 3 on the right, 2 on the left, and you're going to listen. And wherever you hear that wheezing, then we need to try to position the person in such a way that we're going to use gravity to help move that fluid back up the bronchial tree so that it eventually comes out the trachea and they can spit it out or it can be suctioned out. Some of the techniques that we'll use are things like percussion, which is the tapotement, right? The beating kind of on the chest wall. Vibration is kind of shaking the area, or they do make little tools that will sort of vibrate. Again, the idea is that it's going to loosen up the mucus that's there so that we can then mobilize it a little bit more easily. Shaking is like a more vigorous vibration. Again, there is a handout that's posted for you in Blackboard, so please see that about the different positions that are available for postural drainage. Again, the positions are based on the anatomy of the lungs and the tracheobronchial tree. Again, we're going to use gravity. So like basically, if you hear something in their upper lungs, the person is probably going to be seated so that it drains from the upper part of the lungs down into the bronchi so that it can be expelled. If we hear something in the lower part of their lungs, we're going to need to kind of invert the person, right? So we're going to need to position them in such a way that their feet are higher than their head so that we can move those secretions. So we do have postural drainage tables that can be elevated on one end versus the other. Our hospital bed in the acute care lab can do the same thing, or tilt tables might do the same thing. The Trendelenburg position is a patient who's in supine, but their head is going to be lower than their feet. So it's a head down position. The bottom of the bed will be inclined. This helps with the lower lobe secretion removal. So again, we're elevating the feet higher than the head. It can also be used to increase blood pressure if someone has hypotension. It's contraindicated or shouldn't be used with patients with congestive heart failure, pulmonary edema, hypertension, or shortness of breath because they won't be able to tolerate that position well. The reverse Trendelenburg is again patient in supine, but the head of the bed is raised and the foot of the bed is lowered. This also can be used for patients with hypertension and other cardiac conditions, but this will help to mobilize secretions from the upper to middle parts of the lungs. And then the semi-Fowler's position is a patient supine with the head of the bed elevated to about 45 degrees and then pillows underneath the patient's knees. This is pretty typical of the position that you will see a patient in if they are in a hospital bed. This can be used for patients with congestive heart failure. All right, that is it, guys. If you have any questions, please reach out or we can talk about them in lab. Thanks.